All right, I think we're ready to start again. So welcome back, everyone. Thank you. We've got an exciting second half of our symposium this afternoon, and we're going to start off with Carolyn Canfield. And Carolyn is someone who, after her husband's unexpected death, after successful surgery, Carolyn rose above the tragedy to learn about safety and changing the culture for better experiences for patients and healthcare workers. Carolyn has become a passionate advocate for strengthening the patient-practitioner relationship and is a founding member of the Patient Advisors Network.
Test, test, test. Is this good? Okay, great. I'm ready to go. Okay. So this is my story of participatory action research, and it, of course, begins with a story of mine. The shock of my husband's death was actually greater for the health professionals who were caring for him 10 years ago. And that was astonishing to me. I wasn't prepared to see the devastation of the nursing staff. I held those nurses in my arms to try to console their convulsive sobs to no event. And I thought, how can this be? These are professionals. It's one thing for me to feel that loss and shock, but what about the professionals? Well, there would be no case review. For an unexpected death in hospital, how could this be? So not even the professionals would learn what happened. How could we ask such caring and deeply caring workers to cope with this shock? I knew that healthcare was based on science, on meticulous attention, on precision, on knowledge, on evidence. I trusted the scientific method. I knew that hospitals were safe and houses of watchfulness and caring. I knew I could trust the caring environment. I knew that the professions knew exactly what they were doing. They had been trained to do excellence. They were providing the best care, to constantly improve. I trusted the professionals. When catastrophe strikes, this all falls apart. How could it be that no one but I was asking, how could this happen? How can we learn? How can we prevent this from happening to the next patient? Instead, I was told, Carolyn, this happens every day. So the research question that began to take form for me was around the nature of trust. The public's presumptive trust in healthcare, healthcare workers' trust in each other, the patient's trust in those who are providing care. Once betrayed, trust is very difficult to put back together. So to discover the discipline of patient safety felt a lot like tackling Mount Everest, but I was soon to discover the perpetual, pervasive metaphor of the iceberg. So sure enough, this was another iceberg. So I dove deep, sometimes with the guidance of a mentor, sometimes all on my own. I tried to learn all I could from observing, from talking, and from reading the peer-reviewed literature. That guidance took me to places I had no idea existed and perspectives that were new. Too often, this is the patient's experience of care. Too often, this is the health worker's experience of work. And always, there's too little time to connect, Too little time to build trust, to address the threats to trust, to repair the fractures in trust. I had an idea that front-loading trust would insulate us from harm. Much improvement work misses the mark. It further disconnects us. It removes the human interaction. There isn't an apt for trust. See the context in which patients live. See the barriers that are before them in the cultivation of trust. This is where healthcare happens. People joining each other. Professionals, patients, families, neighbors. Building trust to support each other. That means better care for patients, more smoothly running systems, better careers for workers.